Respected panels and dear audience, Assalamu alaikum. I am Dr. Md Resalat Chowdhury, chest surgeon, working in the Bangladesh Specialized Hospital. Today's my topic is surgical management strategy for the endobronchial tumor. Introduction: pure endobronchial tumors are the rare entity and that may present with the deserved pathological findings and may challenges in their diagnosis and management. The malignant tumor are the more frequent than the benign one. Although tracheobronchial tumor represent only 0.6% of all pulmonary tumor and they are clinically significant, these tumors are often revealed incidentally. Symptoms of endobronchial tumor preliminarily depend on the size rather than pathological characteristics of this tumor itself. The early stage of both benign and malignant endobronchial tumors may have similar signs and symptoms which can be misdiagnosed as a pulmonary disease like bronchial asthma, COPD, and pulmonary infection. Most commonly, patient seeks treatment because cough and hemoptysis, chest pain, dyspnea, and localized wheeze and recurrent pneumonia and atelectasis due to the bronchial obstruction. In the absence of airway obstruction, patient may have no symptoms. And diagnosis of endobronchial tumor by CT scan of the chest, multi-directional CT scan, virtual bronchoscopy, and 3D reconstruction film of bronchial tree, and fiber optic bronchoscopy, and endobronchial ultrasonogram, and PET scan. Treatment under considered, the pulmonologist, thoracic surgeon, and anesthesiologist should make multidisciplinary team and make the decision for the tracheobronchial tree treatment. Options: surgery is one option. Another option is therapeutic bronchoscopy and interventional procedure like tumor resection by electrocautery, cryotherapy, and argon plasma coagulation, and laser surgery. What we are doing. This is the bronchoscopic procedure. First, bronchoscope is introduced in our bronchial tree, and this is argon plasma coagulation by resection of the tumor, cryosurgery, cauterization. This is the stenting for the malignant cases. And this is the laser surgery. All these are resection of the tumor by endobronchially. I have some discussions on case. Abul Kalam, 20 years patient. This is a CT scan of the chest and mediastinal window. There is a growth in the left lower lobe, and bronchus is also occluded. And next plan is CT guided FNC from the lesion. And CT guided result is positive for the malignant cell. And on the surgery is lower lobectomy was done along with this bronchial tumor, and histopathologically shows the carcinoid. This is another case, Rogina, 27 years, and X-ray shows there is a lesion in the right upper lobe, and CT scan also there is a upper lobe lesion, and bronchoscopy shows there is a upper lobar bronchus is completely occluded, and scope could not be negotiated in the downwards, and which is bleed on the touch, and biopsy is not taken from them. This is after sleeve lobectomy of this patient. Sleeve lobectomy is very important and very challenging for the thoracic surgeon because full orientation about the bronchial tree and the pulmonary vasculature. And this is the pulmonary saving surgery because some patient needs a pneumonectomy. After all, the resected of the bronchus and end-to-end anastomosis of the tumor-free bronchus, and that after saved from the pneumonectomy. And this is the sleep lobotomy X-ray postoperatively and follow-uply. This is the histopathological report. Another case, Akash, 18 years old patient. There is a X-ray shows there is a radiopaque shadow in the right hemithorax, and CT scan shows there is a growth in the right endobronchial growth in the right bronchus. And endoscopy shows there is a growth in the right principal bronchus, and in there, just after the carina, and left bronchus is seen here, and the right is completely occluded. This is endobronchially removed. There is a soft tissue, and histopathologically, it is a leiomyoma. And after follow-up bronchoscopy, there is some scar mark found after 4 weeks, and there is a chest X-ray revealed almost normal. Nahida having tracheal growth, and there is a bronchoscopy shows there is a growth in the trachea, and which moves with the phonation. A CT scan also shows the mid-tracheal growth, and which is endoscopically resection is done. And histopathologically, there is a mucoepidermoid carcinoma. Mr. Ayov, 53 years, and their bronchoscopy shows there is a growth just beyond the carina. This is thyroid growth extend to the trachea. This is the resection and anastomosis. It is very challenging for our surgeon and anesthesiologist also. And here, in most of the cases, the anesthesiologist needs the single lumen ventilation, but in case of this case, need the LMA tube, laryngeal mass airway tube, and it is fastly introduced after incision. This is the resection and anastomosis. Another case, Mousumi, 38 years, that is histopathologically the mucoepidermoid carcinoma, and there is endobronchially shows there is a large growth and which bleed on touch. This is the lower lobectomy was done surgically. And another case, Priti, 19 years old. This is and the large lobulated mass in the right bronchus, and there is a right lobar bilobectomy, right middle lobe and right lower lobe. Take home message, impossible is nothing. Good logistic, good center, and good teamwork and dedication can make us successful in thoracic area. Thank you.